We'll begin just a moment. All right, well, it's 2 o'clock, and we'd like to thank everybody for attending our webinar series. I believe this is our 8th webinar, so we're excited to have Dr. Michelle Crispo here with us today. She is going to talk about advanced directives and palliative care and hospice and end-of-life care. Dr. Crispo is a emergency physician here at Maine Medical Center's ER and is trained in palliative care also. Dr. Crispo, would you like to meet the group?
Hi guys, thanks so much for having me. Should I start? I'll start, Eric.
You're all set.
All right. I'm just gonna, hopefully I can get onto this PowerPoint appropriately. All right, here we go.
And we have your PowerPoint up.
All right, awesome. All right, so I'm so excited to be here to talk with all of you guys about some tips and hopefully some education on how to better care for our patients that are palliative or hospice in the pre-hospital setting. And I'm also really eager to hear about some of the scenarios or issues you've encountered in the field so we can navigate those. And I always learn from all of you. So unfortunately, I have no financial disclosures. If anybody has an offer out there for one, I would gladly take it. So I wanted to start by just giving you a little bit of my background. So as Eric mentioned, I'm an EM attending at Maine Medical Center. I'm also not only board certified in emergency medicine, but also hospice and palliative care. Although I've never been an EMT or a medic myself, I happen to be married to this very tall firefighter and paramedic, my husband. I promised I wouldn't embarrass him. So he works for the city of South Portland. Because of being married to a firefighter and paramedic, I think I have a different understanding of just like how absolutely unique and often, let's just say it, absurd challenges that can come up in the field. I also wanted to kind of share with you, all of us, at least in part, went and chose these careers to help save lives. This also includes myself. But when I started to go through medical training, I really noticed there was something missing in medicine. I found that the focus certainly was on, life prolongation and treatments, but there was very little focus on care at end of life. This sort of evolved into a passion of mine for recognizing that, yes, end of life is not only inevitable, but it's like this really important stage in our life journey. Anybody who's lost a loved one will probably agree that the memory of those last days or weeks or months are really an incredible kind of journey. Making this stage meaningful, less scary, and providing patients with a sense of dignity did really become a passion of mine through med school. So it inspired me to pursue a fellowship in palliative medicine. And for those that aren't familiar with the lingo, a fellowship is essentially extra training beyond the very lengthy training you've gone through to kind of focus on an area of expertise. So as you guys know, there's an EMS fellowship. So there's also a palliative medicine one. I also, before we begin, wanted to just point out, talking about end of life can trigger a lot of strong feelings and emotions for people, whether it's personal or prior patient experiences that you've had. So I just want to put sort of a thought out there just to be kind to yourself. And if this discussion triggers anything, certainly reach out for support. Okay, so here's what we're going to talk about today. So this is not only our outline, but kind of objectives for learning. So what is palliative care and hospice? A lot of doctors honestly don't understand the difference between these two, which we'll talk about. And then I want to delve into code status, not only kind of the types of code status, but also what the actual outcomes are after cardiac arrest and what considerations we need to have in terms of who tends to do better or worse in terms of patient factors. I think it will sort of set the stage for understanding why these conversations are so important for folks. And then we're going to go on to talk about documentation of code status, including advanced directives, pulse, verbal communications, and what your kind of legal obligation is in terms of being handed these in the field or being verbally told a certain code status. And then I really hope we have time to open up the kind of pathway for you to ask questions or share scenarios that you've come across that were difficult. Again, I learn as much from hearing from you as I'm sure you learn from listening to this. So when we talk about palliative care, so essentially people are usually pretty confused by what it is. And essentially what I tell people is palliative care is like the umbrella, and hospice is a small part of that umbrella. So palliative care is really an approach to medical care for patients who have serious illness. And when I use that term, I mean cancers, strokes, heart failure, any type of progressive illness. But keep in mind, palliative care is also for patients who are seeking cures. We care for little neonate babies all the way up to elderly patients. So just because somebody's choosing to have their care be palliative focused doesn't mean a cure is not in sight. The whole idea of palliative care and why it's so awesome, and in my opinion, superior to the care we provide in this country, is it really takes care of the whole person. So not only do you get cared for by a doctor, there's a social worker involved, and spiritual care or chaplain is involved. So it's really looking at the whole patient, and in addition to dealing with the serious illness, really focusing on quality of life. And during that process, as the disease changes, whether it gets better or worse, having goals of care conversations along the way. For example, some people, when they start the process, may be a full code. Sometimes when disease progression continues, they may change that code status. So I wanted to delve into a little bit deeper into that difference between palliative care and hospice. Again, it's confusing for a lot of people, and a lot of doctors confuse the two as well. So basically, there's commonality between the two. So that green area is what is the common features of both hospice and palliative care. So both care systems, if you will, are patients with serious illness that really feel that a multidisciplinary approach to their care is important, as well as a focus on their quality of life. So unique to palliative care is that there's really a variable prognosis. So like I said, people can have terminal illness and be enrolled in palliative care, and they can also be in a situation where cure is possible. In patients who are like termed palliative care or using those services, a lot of times they are still seeking disease directed therapy. And when I say that, I mean that they're wanting to pursue dialysis. They want to consider or go through radiation or chemo. They still want to come to the hospital if they get sicker. Palliative care patients can have a variable code status, like we had just talked about. You could be a DNR, you can be a full code. It's sort of the whole gamut. In contrast to that, let's talk about hospice. So specifically, in order to kind of qualify, if you will, for hospice, two different physicians have assessed you and have determined that you have a prognosis that is less than 6 months. So different than palliative care, this is really patients with a terminal prognosis. When somebody chooses hospice, they are not seeking curative treatments anymore. They're really focusing on comfort. Most hospice patients, really the goal is not to go to the hospital or to avoid the hospitalization, which we'll talk about. In all reality, if somebody's on hospice, their code status really should be a DNR DNI. There are very rare religious exemptions where I have seen people on hospice that are full codes. But I want to sort of highlight, if you end up caring for a patient or are called to a patient's home that says they're on hospice, but the family is reporting they're a full code, it is likely that they either don't fully understand sort of the spirit or goal of hospice, or whoever enrolled them in hospice really didn't dig deep to make sure they understood the process. So, yes, it is possible you will see a hospice patient with a full code status. But in my experience doing this for a while, those are patients or families that really didn't get vetted, if you will, for really what they want with their care, or there was sort of a miscommunication or misunderstanding. So let's talk a little bit about hospice and what it looks like. So we talked about the WHO, right? The WHO is, these are people that are terminally ill seeking more of a comfort focused path. Hospice can occur really in two settings. So one is outpatient, and what that means is that's a private home, assisted living, or a skilled nursing facility. I know we don't typically think of a skilled nursing facility as outpatient, but for these purposes and for hospice, we consider it outpatient hospice. And then an inpatient facility would be either in the hospital for comfort focused care, or a hospice inpatient facility. So those of us that are from Southern Maine are probably most familiar with the Gosnell Memorial Hospice House. There are others throughout the state. For folks that are further north, there is the Androscoggin Hospice House in Auburn, and then there is one at Penn Bay as well. And so, what exactly does hospice mean? So, hospice is really a multidisciplinary team, as we talked about, where the goal of it is that the care team comes to the home or place of residence. And when I say home, that could be assisted living or a SNF. The team consists of docs, nurses, CNAs, there's chaplains for spiritual support, and social workers. The, the hospice patient will enroll in a specific agency. And I know we probably have a really big geographic distribution here today listening to this. And I myself have the luxury of being in Southern Maine, where the resources are really rich. And a lot of our hospice agencies are pretty robust support. I have cared for patients that are really like up north, and where the hospice agencies are really not what they are down here, what we expect them to be. There are certain sort of hospice teams on various, I know like on Orr's Island, it's a volunteer team that helps. So keep in mind, this sort of ideal setup for hospice is really in more resource heavy areas. And when you start getting into rural areas like island living, it's not going to be as robust as a system, which is important for you to know as well. So the hospice team brings the care to that patient's home or place of living. The goal is for them to stay at home for end of life. And essentially, meds will be brought there, equipment, commodes, beds, etc., to make that possible for them to stay. The last two pieces I think are really critical for pre-hospital clinicians to understand of hospice patients. So every hospice patient is given what's called, we call it a comfort kit. And it is literally like a small box with medications that are available to treat end of life symptoms. So in that box, you're going to see high concentration solutions of Ativan, Haldol, morphine, and the Zofran will be ODT. The whole idea of it being in liquid form is that as end of life progresses, there's oftentimes a loss of ability to take pills. So these meds can be given buccally. And we'll talk about why this is important for you guys to know that that's there. The most common location that we will put it is in the refrigerator because it can't get lost. It's sort of out of reach of small hands, and the refrigeration helps those meds stay more bioactive, if you will. Another really important piece for pre-hospital clinicians to know, if you get called to a hospice patient, there is a registered nurse on call 24/7 for emergencies. The hospice team or agencies, their goal is to avoid a patient coming to the ER or the hospital. It benefits them, but it also aligns with the care that the patient has requested. So this is something that not everybody knows, but it's important to know. Again, depending on what location you're in, if you're in southern Maine, this is pretty readily available. But again, if you service islands or really rural areas, it's possible this is not going to be kind of as robust, if you will. So why would you get called to assist a hospice patient? So there's a couple of reasons. So I always want it to ring a bell for you guys. So if you're getting called to the house of a hospice patient, there's something that's happened that they are off a normal hospice trajectory. So it should be very unusual that you're getting called, but it happens more than you would think. So some of the reasons might be an acute injury, somebody's fallen and unfortunately maybe has a hip fracture. There is not infrequently a misunderstanding of what hospice is. So these are patients and families that whoever enrolled them in hospice did not really fully engage them in what it means, which should be the goal of staying home. Refractory symptoms are certainly a very legitimate reason to call the ambulance. It's possible those comfort kit meds or whatever meds they have at home are just not doing the trick. And in those scenarios, sometimes they need to go to an inpatient facility for IV medication. Such as Gosnell or sometimes hospital itself will have to be that, especially in the rural areas. And sometimes families and patients panic and get distressed. I know there's probably some people here from MedQ. There's a particular patient that is showing up like 2 or 3 times a week who has end stage COPD. And when her breathing gets bad, she panics and calls 911. So that's certainly a situation you can run across. And then sometimes people change their mind. So you have a patient with like maybe end stage heart failure who's really volume overloaded and changes their mind and says, you know what, I don't want to be on hospice anymore. I want to come back to the hospital. I've changed my mind. And that's okay to do. Just because you start hospice, it doesn't mean you have to stay on it. I have my experience taking care of a lot of patients. It's very unusual once a patient sees the benefit of the care team and what hospice can offer. It's very rare that somebody will choose to opt out of it once they've started. And so what should you do if you get called to the house of a hospice patient? Just going to pause and let you know this is my dad. So when he was facing end of life, he chose a hospice kind of focus plan. So Jason and I moved him into our house and we took care of him at home. But what should you do if you get called to this house with where there is a hospice patient there? So like we talked about, your alarm bell should go off, right? Something's off if you're being called to the home of a hospice patient. So that should really trigger, like, this is a unusual call to get. Is there something we're missing? So the first thing I recommend that you do is confirm their hospice status. I have had a lot of kind of folks bring patients to me in the ED and say, oh, I think they're palliative, they're hospice, but just confirming that they're actually enrolled in hospice is really helpful, because sometimes it's just the family sort of trying to relay, well, we're strongly thinking about it, but they haven't quite done it yet. That's important for us to know. And then have they called their hospice agency? So if the patient's being cared for by a good hospice agency that has a lot of resources, which again, as we discussed, could be very geographically sort of variable, they it's the default. If there's an emergency, they are not supposed to call 911. They are educated whether they listen or not. Sometimes people panic and forget what to do, but they are supposed to call their hospice agency first. So if there's a fall, if there's a medication issue, if they have uncontrolled symptoms, they have been told, whether they remember or not, that the first call should go to the hospice team. And then what do they need? So are they having poor symptom management? It's possible the family member forgot about the comfort kit and didn't even try to use that before calling you. Did they fall and break their hip? In that scenario, they need to come to the ER. So any falls with significant injuries, I do like and recommend them to come to the ER. The perfect example being a hip fracture. So if a hospice patient falls and breaks their hip, it's unusual that I won't recommend them repairing that hip and coming into the hospital transiently. The reason for that is losing mobility is a quality of life issue, which is what we're all about with hospice. And then pain from that not being fixed, especially like an intertrochanteric hip fracture, is also an issue with quality of life. So ambulation is part of quality of life and pain control. And then, have they changed their mind? Are they getting more respiratory distress and they sort of decided hospice isn't for me, I'm going to change my mind? Or sometimes it's simply that the family is panicking because end of life is approaching soon. And that's not to say these patients can't come to the ER. They all can, but it's nice to sort of have a background to think about why you might get called to a patient's home. If they haven't called the hospice agency and it's not sort of a dire urgency that you feel like until you can figure out the goals or work them out, you're going to scoop and run. If it's reasonable to take time to call the hospice agency with them, that can be really helpful, because you may find the nurse is like, oh, I'll be there in 5 minutes. So even if it's 2 a.m, there's a nurse on call for that type of situation. And Eric, I was just going to pause right there to see if there's any like hospice or palliative specific questions before we move on to the next part.
Folks, if you have any questions, please feel free to put them in the Q&A function or the chat function, and Eric and I can help alert Dr. Crispo if needed.
All right. All right, I'm going to keep rolling so we don't get too far behind. So I wanted to talk a little bit about code status. I want to talk about outcomes as well as patient factors, not because you are going to be having these conversations yourself, but I think it helps to give some background on why people are making certain decisions about code status. So patients that kind of have more positive factors when they arrest, VFib, VTAC is a more favorable outcome. Unfortunately, 80% of codes are going to be PEA, but those 20% that are VFVT are more favorable. A lot of times they're still perfusing rhythms, but we also can treat them better than we can PEA, and they respond better. The other positive factors you guys are well aware of, so it's very kind of intuitive, right? The sooner you get ROSC, the less time there's chest compressions, whether it's witnessed, how far away EMS is, and how quickly they get there. Negative cardiac arrest factors are also fairly intuitive, but I think important to kind of think about in our patient populations. So obviously we talked about asystole and PEA have much worse outcomes, and unfortunately they're the majority of the arrests that we encounter. Any chronic illnesses, so each chronic illness you have reduces the likelihood of the fact that you're going to survive by like an odds ratio of 0.84. So, and when I say chronic illnesses, specifically strokes, heart failure, coronary disease, cancers, Alzheimer's, dementia is actually shown to have very poor outcomes with resuscitation. Age is fairly intuitive with the exception of pediatrics. Outcomes, unfortunately, with pediatric arrests, especially under the age of 1, are oftentimes actually worse than they are for adults. The reason behind that is when a pediatric patient arrests, it's typically not something reversible like a cardiac ischemic event. It's usually something that's quite lethal. But age, in terms of older age, anybody over the age of 90, there's a less than 2% chance they're going to survive to hospital discharge. And over 70, it's less than a 70% chance. Gender's interesting. Men tend to have better outcomes than women. But we think this is not because you're superior. Don't get too excited. Men are more likely to have ischemic heart disease and present in VFVT rather than PEA than women. And then trauma and sepsis are poor factors. So I do think it's important being clinicians that do ACLS on a weekly, if not more frequent basis, important to know what the outcomes are. So in terms of out of hospital, so this is survival to hospital discharge. So of those that arrest in the field and we get ROSC, about 10% of those actually survive to hospital discharge. If you see numbers higher than this, it's because people are using like survival to the ER or survival to the ICU, but these are like very well-known numbers. It's more like 8%, but I find 10 and 20% to be easier numbers to remember, but it's actually a little bit worse than 10. In hospital, it's better, which makes sense, right? Because we talked about those positive factors with cardiac arrest, but with those, about 20% of patients survive to hospital discharge. So again, palliative care, we're always thinking about quality of life. So in most patients, yourselves included, most people say, well, I survived, but what does my life look like? So, and what that means essentially is what's your neurologic outcome? Can you function? Can you feed yourself? Can you still live independently? So when I talk to folks about what's important to them in terms of their quality of life, that's a very common theme of being able to live independently. So these studies that look at good neurologic outcomes will define a good neurologic outcome as a cerebral performance category of 2 or better. And you don't need to know that piece per se. It's just how we evaluate outcome. But essentially that is someone who can still live independently. So that's really the line between being able to go into a nursing home because you had an anoxic brain injury from your arrest and can't care for yourself versus being able to live independently. The number so basically out of hospital, 7% of patients of that 10%, right? So 10% of people that actually survive to discharge, of that 10%, 7% have a good neurologic outcome, which is like pretty awful, right? Just 7% of those. The in-hospital cardiac arrest numbers for neurologic outcomes are much stickier. They're not as clean. Like this CARES registry in 2020 did a really thorough look at out-of-hospital cardiac arrests across the country. But in hospital, there's still like a lot of data that's all over the place. So I will say this with a question mark, but there's different papers and it's very controversial, but maybe 30 to 50% of in-hospital arrests have a good neurologic outcome. But again, not as consistent or reliable as that 7% number that we know from the CARES registry. So sometimes I get this question like, well, what's the harm in trying CPR, right? So when we think about the outcomes of CPR and we think about the risk if somebody gets ROSC that they have sort of a poor neurologic outcome, the risk of trying CPR is that it may end up in a quality of life that's really unacceptable to that patient. So, what we know from a lot of robust studies, anecdotally from me taking care of a lot of end of life patients or palliative patients, talking about what's important and if end of life is near, what we know that they want is they want reliable medical information. They want relief of pain and symptom management. They want to avoid a prolonged dying process, and they don't want to be a burden to their family. They want to not only receive end of life care in their home, but they want to die at home. So when I get that question, what's the harm of trying CPR? In certain patients, it may rob them of an end of life that they have expressed wanting. And that's where the harm comes. I will tell you, I am not doing this lecture to say that everybody should be a DNR, but I think more thought needs to go into certain patient populations that are at end of life or are dying from a chronic illness that we can't cure or fix. Really, that's the conversation we have. What is their end of life going to look like? Being able to give patients control with that end of life is an amazing gift for the patient, but also for the family. I don't know if anybody's had the really tough experience of trying to decide whether they're going to like pull the plug on their family. It really feels like you're doing something active versus when patients choose less invasive measures at end of life, it doesn't feel so active like you're taking something away. It's merely kind of supporting them with a natural process rather than this active decision that really feels like you're pulling the plug of life that the family members almost caused the death. That's also a big harm that I've seen is like that burden of the family of feeling like they sort of expedited that loved one's death. So I'm going to move on to code status. I wanted to talk briefly about sort of the different flavors of code status, which I like to call. It can be very confusing. So there's really four. Not every hospital system uses that tailored, that nomenclature of tailored. We do at MaineHealth, and we'll talk about that. Full is like the vanilla ice cream, right? It's easy. You resuscitate, there's no limitations. DNR DNI means they don't want resuscitation, they do not want to be intubated, but I always want to emphasize that that doesn't mean they don't want treatment. So just because they don't want resuscitation in the event that their heart were to stop, it doesn't mean they don't want to come in for BiPAP, doesn't mean they don't want to come in for IV antibiotics for UTI. So it's really important to separate that. That is different than comfort care. Tailored code status is what you'll see. The perfect example is that, I'm a DNR. If my heart stops beating, I know the outcomes from cardiac arrest are so poor. That's not for me. But I have COPD. If I had a pneumonia, I'd be okay if I needed an event, if it was short term. And this is a patient, maybe like, for example, a COPDer that is in their 80s. We saw this with COVID, where a lot of those folks, you're like, this isn't going to go well, but you put them on a vent, their lungs healed from COVID, and the vent came off. What is not an acceptable code status for tailored is when they say that they want chest compressions but don't want to be intubated, right? That doesn't make sense. All of us have done God knows how many codes collectively in this kind of virtual learning space, but there's maybe one case I remember where we did chest compressions and defibrillated and the guy woke up. But normally if somebody's getting chest compressions, there's a tube going in. So I do not allow that as a tailored code status. I say that's not on the menu. That's not possible. You can't want chest compressions but not intubation. They come together. And comfort measures only is really what we talked about, that hospice patient. So not only are they a DNR, DNI, but they are choosing comfort focused care only. They don't want to come to the hospital, and they're really focused on just quality of life. So with code status comes documentation of it. And this is where it can be really challenging for you all in the field, and also for us when patients come in, not only unidentified, but they're elderly, they look really frail, and we have no idea what their code status is. It can be really tricky to figure out. So in order of preference, I'm going to talk about post form, physician signed DNR order, advanced directive. So the cream of the crop is going to be the post, and then going down in order of helpful documents is the bottom, the verbal. That's really tricky. So let's talk about the post. So this is like your jackpot winner, right? So the post is also it's sort of a abbreviation for physician orders for life-sustaining treatment. So this post is a physician signed order. It may be not the clearest to see. Most of us have seen these. They're on bright green paper. They're supposed to be, so they really jump out. But the top box is really the money, whether they want CPR or not. The second box is also useful for EMS. It talks about whether they would want like non-invasive, like would they want to go on BiPAP, CPAP, or are they comfort measures only? And then the lower sections are not as helpful for you all, but they talk about things like feeding tubes, antibiotics, hydration. But this is like the best communication tool of patients' wishes. And further past that is it's an actual order. So if you go to somebody's home and there is a post there saying they're a DNR, you, by Maine state law and Maine EMS policy, you can use that as a directive and not start CPR. You don't have to call med control or anything. You can use that as a DNR order. Below the post, I like to call kind of like the scratch ticket, right? It's not as great as the jackpot, but it's really a physician order that says DNR. It works great. It's perfect for what you're going to need pre-hospital if there's a resuscitation question in terms of what they want. But that by Maine state law and EMS protocol here, you can use that as a directive without having to call med control to confirm. In advanced directive, these kind of drive me crazy. I don't want to bias people, but they are like 8 pages long. And so for the pre-hospital setting, they are not very useful unless at the very end, like on page 8, sometimes page 12, sometimes there's a physician signed DNR. So for your purposes, the only thing that's helpful with these advanced directives is if there's like a physician DNR order, and that is at the very end of this heavy packet. I don't love this packet for a couple of reasons. Advanced directive is a term not many folks really know. It's sort of a confusing term. And then the term I hate even worse is a living will. So advanced directive and living will are the same sort of, it's the same term. But I find when people are asked if they have a living will, they start talking about like, oh, my cat's going to go to my nephew and my house is going to go to so-and-so. They really confuse it with like an actual, like a state will. So I hate the lingo. In the hospital setting, what can be helpful with this advanced directive is that it assigns a power of attorney for healthcare. So if there's any confusion over like who's who in the zoo or who's in charge, that can be helpful in terms of knowing who is like the legitimate or legal decision maker for healthcare. But in the middle, you can see I really don't what patients are asked to check off. It's really vague stuff, and it really doesn't apply to real life. Like when people check these off, I can't really like extrapolate that onto their care. But for all intent and purposes, the bang for your buck will be the very last page if it's in there and if it's signed. That might be helpful for you.
Dr. Crispo.
Okay, so yep.
We have
I
a few
wanted
questions
to,
in the chat. that might be
yeah, and that's the end of my slide, so we can chat.
I can't hear. Sorry. One of the first questions that's in the chat was back from the hospice section. How should an agency respond if the hospice agency is non-responsive?
Yeah, that's really tricky to it depends on the situation. So if you don't know what to do, obviously you can bring them to the hospital and we'll figure it out. But that's really depends on the situation. I would encourage you, I don't think it's Matt, maybe you'll disagree, but if you go there and there's sort of symptom management issues and you realize the family forgot about the comfort kit or the box, I feel like do you agree, Matt? It's reasonable to sort of walk them through that.
Yeah, Michelle, thanks for that. There was another question in the chat about the comfort medications and how to interact with those. And if folks want to take a look at Gray 8 and 9 in the MaineHealth protocols, Dr. Zimmerman taught us recently that Maine and I believe Ohio are the only states with hospice protocols in them right now. What we do in those in the protocols is kind of define what those medications are and then walk folks through a process of how to interact with them. I'll also mention that the first call in these situations really should be to the hospice agency, and we had some other questions about how do we get that number, and the best way to get that number is to ask the family, loved ones, care providers, or patient for the number. It should have been provided to them. We've also had questions about, is there a statewide number? And unfortunately, there isn't a statewide number. If you have trouble getting a hold of the hospice team caring directly for the patient, another option is to reach out to online medical consultation, who can also walk through some of these issues with you and can support your decision making as you're going through some of these highly nuanced situations. Thanks for that, Michelle.
Yeah, that would, so like I said, depending on the situation, like I said, if somebody's broken a hip or is injured, sometimes even like if a patient smacked their head and maybe there's a head bleed, that is more than appropriate to bring them in, because if that hospice patient does have a head bleed, even though they're not going to change their kind of hospice or comfort approach, it can help the family with prognosis, which anybody who's cared for a sick family member, it's really hard predicting, or it's uncomfortable kind of knowing how long they're going to have. So that's more than appropriate. And I would almost encourage you, if there's concern that there's an acute injury, I'd really want them seen in the ER. But like I said, symptom management, it may be that the family just, and you guys know, we have a lot of patients who have elderly caregivers. Like, I do not know how a lot of people function, but it's really hard to remember, oh yeah, the nurse said there's that box in the fridge and this is when to use it. If it's helpful at all, I can also, through Eric or Matt, I can send out a list of the concentration that those meds are in and what I would recommend starting with in terms of doses if you end up having to give them. Again, they're very high concentration for a reason, because they're meant to be absorbed buccally. So they're small, the actual doses are small volume.
Have some additional questions. How best to find the emergency RN number, which also links to is there a statewide hospice hotline number?
That's a great question. So no, there's not. So there's hospice agencies throughout the state. So some examples, Hospice of Southern Maine is one. Androscoggin just changed their name. There's northern light. So a couple of things, there should be a magnet or a contact information in the home. I also appreciate, because of who my husband is, homes are nasty sometimes and you can't find anything, but you can always like jump on your phone and Google. If I feel like you probably will be able to figure out what hospice agency they're committed to. But that's a great question. It's not like a whole hospice. It's not like a state hospice team. They're all private agencies, which vary, like I said, throughout the state. If you're in rural areas, I guarantee you're not going to get a good response. You're going to be kind of troubleshooting from the hip. I even sometimes have had trouble getting hospital beds depending on where the area a patient lives, especially like the islands. So yeah, just depending. There should be, usually the good agencies, not to be snobby, usually have a magnet on the fridge and a number, but just hopping on your phone and going on that website, you should be able to figure it out pretty quickly.
Excellent, thank you. And if a pulse form is filled out but not signed, what should they do?
If it's not signed by a physician, you shouldn't use it. It's not really a completed, it's not a completed form. But I always encourage you guys, if you have a patient and the pulse form is filled out, but it's not really signed, that would be a good role for med control to kind of call the local ER. If that family is like, hey, look, like this patient's a DNR, somebody forgot to sign at some area, that would be a good role for med control and say, hey, we think this was just sort of a misstep, and can we honor what the family's telling us?
Excellent. Follow-up question was, do any of these documents have expiration dates after they're filled out?
So that's a great question. Shoal and I were talking about this. We used to have a rule that you had to renew pulse form annually. So after a year, it should be discarded, but that we got rid of that rule, correct, Matt? Yeah.
Yeah, that was dating back to the 2010, 11, 12 timeframe when that rule was in place, and it's since been eliminated and no longer a part of the common practices around pulse, and also therefore no longer part of the decision making in the MaineHealth protocols.
Mm-hmm.
As a follow-up, can the pulse be signed by a physician assistant or a nurse practitioner?
Yes, it can. Yep.
Excellent. Excellent.
Sorry for being physician centric, but yes, that's legit.
We appreciate it. Are the code statuses easy to understand on the documents when they have multiple choices?
That's a great question. So yes and no. If it's on, usually if a post is filled out, PAs, NPs, or docs that are filling out polls are usually very mindful, if they're using it, of being very specific. For example, on the post, on the section for like airway management, there's a specific checkoff or agreement if they want to pursue or decline like non-invasive. But that's why the post is like the jackpot, because none of the other documented goals of care actually tease out things like non-invasive or not. So the post, it's pretty clear. But again, if there's any question, or if you're in a bind, I tell people, if it's really unclear or you're not sure what to do, it's okay to just do the more aggressive pathway. Like if things are really confusing, or you show up and there's one family member saying they're like a DNR, one family member saying they're a full code, there's no documentation, the safer thing is to do more, and then we can always pull back at the hospital once we tease things out. So I always tell you, if you're not sure, it's better to do the more aggressive path, and then we can tease it out later. That would be my recommendation with confusing kind of goals, either expressed verbally or written.
Thank you. If a patient or a family member wants to get a DNR, who should we refer them to?
Yeah, that's a great question. That can be done through their primary care office. That's the best thing to do, but any doctor can do it. Say there's a lot of folks we take care of, right, that don't have regular health care or don't even have a primary care. An ER doc can sign that, an NP or PA as well. So that can be done easily in an ER visit if it's asked for. But the more common path, if somebody has a primary care doctor, is it would be done through them. But as we all know, that discussion and documentation doesn't always happen smoothly or the way we would like it.
Excellent. Let's see.
And
Are
people are
advanced
using both.
directives, sorry, are advanced directives a legal document if not signed by a doctor or dated?
That's a great question. They are. So advanced directives, with the exception of that DNR form, do not need to be signed by a physician. They just need to be witnessed by two separate people. So like in the hospital, like if they want to fill it out to assign their power of attorney, you just need two witnesses. It doesn't need to be somebody medical. But that last, like if it's a DNR, that's considered a medical order. So that has to be filled out by a doctor or mid-level provider.
Excellent. Only about 7 more questions to go. Could you explain the relationship between a patient's healthcare proxy, power of attorney, and how the decisions are made regarding the patient after their code status has been determined?
Yeah, so there's sort of like a hierarchy of decision making in healthcare. So the top of the heap is called a guardian. So guardians are assigned by a judge, and those are for patients who don't have ability to make their own decisions. So these are like brain injured patients. Sometimes I will get a judge to sign a temporary guardianship when somebody is like on ECMO, or we know they're going to be on a vent for months at a time. So a guardian trumps everything. Under that is a assigned a medical power of attorney, and what that is essentially is that a like say me, I would say my husband is my medical power of attorney, and I sign that. If you don't have either of those and a situation comes up where decision making needs to happen, the state legislature, excuse me, has like a tree of who goes first. So if there's neither a guardian or POA and the patient can't make decisions, there's sort of a ladder of who gets to make it per Maine law. So the first person on that ladder is either a spouse or a domestic partner, and then below that is an adult child, and then below that is like an adult sibling, and it kind of goes down like that.
Thank you. Can a hospice patient ever put their enrollment in hospice in jeopardy by going to the emergency room?
That's a great question. No, but if they go to the ER, they have to revoke their hospice status. So say they break their hip, they have to come off temporarily from their hospice status. And all that, they can still stay a DNR, they can still stay a DNI, but hospice is really, not only is it the type of care they're getting, it's actually how Medicare pays for those folks. So if that hospice patient decides, which I would recommend to get their hip stabilized, then they would come off of hospice temporarily, but they can always go back on.
Great, thank you. Matt, this one may be for you. If we follow the instructions for a comfort kit meds and administer them, do they document them in the narrative?
Yeah, thank you, Eric. There's a couple questions about comfort kits, and I'm happy to answer them. This one, yes, our documentation is the place for us to document the medications that we provide or that we assist a patient in taking. And it's the only place that can be documented. So yes, our run report is the place to do that. Now, if there's a medication that's not common to you, that doesn't necessarily, you can't log in anywhere else, placing it in your narrative is an option for that. There's another question about whether or not, I think Kevin asked, as a basic EMT, are we allowed to administer comfort medications? The answer is kind of. So we're in the protocols, you'll see listed out that we want you to do a medication inventory, know what medications are available, and to do a medication check and see what medications the patient has taken. And then there are options at the EMT scope of practice that allow you to assist the patient or the family in providing those medications. I'd also ask that none of those medications are common to the EMT scope of practice. So if there are any questions, again, reaching out to either the hospice team or online medical consultation can be invaluable as you're trying to determine which medications the person should get at what time after the medications they may or may not have received.
Excellent. Let's see. What else do we have? Final questions. Is there a way for hospice and physicians to encourage to emphasize to patients that forms need to be with the patient?
Yeah, so that also goes back to like varying kind of quality of hospice agencies. So a good hospice agency will fill that pulse form out, and very commonplace we tell them to put it is on the refrigerator. So it's part of the conversation that should be happening with hospice. And again, it's one of those things that best practice is to fill that pulse form out, and it needs to be like visible if somebody were to come. And we typically, a place that you could look for it where we usually tell them to put it is the refrigerator, or patients that are bed bound, like kind of on the bed frame itself. But again, it's like ideal versus like what actually happens can be different.
Excellent. Do patients have access to pulse forms without meeting with a doctor, PA, or an NP?
You can print one, but you have to it has to be signed by a doc, PA, or NP for it to act as a medical order.
And if the patient or family says that the DNR is signed, but they can't function, what should they do?
Yeah, that's a really tricky one. I think, and Shoal, you can correct me if I'm wrong, but I think by protocol, you're supposed to call med control to kind of come up with a solution. But technically, most of the time people are not like have ill intention or whatever, but you always want to be careful with protocols. But I believe if you call med control to talk about it, you can honor it. Is that right, Shoal?
Yeah, so we did change that in the most recent protocol update. It used to be a little bit more restricted. However, what we've said in the protocols most recently is that you can always call online medical consultation if you have questions. This is one of the most difficult things that we do in EMS, but we ask you to work with the on-scene loved ones, family members, etc., to determine their impression of the patient's wishes, their impression of the family's wishes, if not the entire family is present. And certainly reaching out to online medical consultation if you have questions about what to do is fair, but if you're able to rapidly acquire an understanding of what the patient and the family would want, then you can follow that directive by the patient or family. Interestingly, this is not just challenging in Maine. I was just at a conference last week listening to state medical directors from across the country, and all state medical directors have wrestled with this situation. Although all of the states have come to a very similar place, which is we have to do our best with the information we have available, using the people on scene as the patient's proxy since they can't advocate for themselves. And if there are questions, reaching out to consulting online medical consultation is the best option at that point.
There was a follow-up to that DNR question that I thought was interesting. What if the family member withholds the DNR because they want their loved one to be resuscitated?
Yeah, that's tricky. I think, like I said, if there's weirdness, if you can't physically see the signed DNR, but they're like won't give it to you, that's certainly a weird situation. I think that's pretty unusual. That would be a very rare situation. But like I said, if you're not sure, just lean on resuscitation, and we can always pull back later. That would be pretty unusual situation, but possible. So just, like I said, if you're not sure, either call med control or lean on more aggressive care, and we can always transition later to honor their wishes.
Additionally, can a notary make any of these a legal document?
Not, no, nope. A notary cannot make a DNR, it cannot sign a DNR. It has to be a physician, NP or PA.
And let's see, are photocopies legally binding?
Yeah, photocopies are fine. The whole point of the post is that like the bright green color, not the whole point, but part of it is it's that bright green color that you can see. That technically is supposed to follow the patient, but it's not like a deed to a house where you absolutely need the original. A copy is fine to go by.
Oh, and they keep coming.
I
Eric,
love
I've got
it.
one.
These are great questions.
Yeah.
Eric, I've got one. The question is, do we take the DNR certificate paperwork with us for EMS reporting and include it in our run report? I think the answer to that one, Donna, is that it depends. If the patient is being transported to the hospital, then yes, that's an important piece of information for the hospital to have as well. If you're not transporting the patient from the hospital, you're leaving them on scene, then the DNR certificate / paperwork, post, whatever, should always stay with the patient. And as far as your inclusion in your run report, there's a couple of ways to do that. You can document it in your narrative. You could take a photo of it and upload that photo into the run report. There are a couple of different ways you can account for documenting the patient does have a pulse, etc.
And let's see, patient management, patient-centered devices for pain management. What are the licensing restrictions on transporting a patient who is administering their own pain meds?
So I think these are also referred to as CAD pumps. So CAD pumps are actually under lock and key. So it will have the palliative or hospice nurse will have the only lock to the actual medication area, as well as the area where you can change dosages. So that shouldn't be an issue. It would be like transporting someone with like with a VAD or something, but that pump, it is under lock and key, so it shouldn't be an issue transporting someone with that.
Excellent. And I think this is the last question. How is it handled when acting in accordance with the wishes of a present family and friends, but no actual paperwork is present, and later a higher person on the ladder you spoke with disagrees? How about the care?
Yeah, that's really hard. And I think that's where if you don't have paperwork, but you have family there that are saying, yes, this is what the patient would want, I think the safest thing from a legal standpoint is to talk to med control, and get another sort of approval by the physician, document that it was discussed, and then whatever's going to happen is going to happen. But again, that's a very rare that. And I will also back up by saying that whole triaging of decision makers is really not for the outpatient setting. That's really for patients that are in the hospital, vented, we're making decisions. So that kind of triaging is not something we would expect you to do pre-hospital, but it's just more kind of for your information. Like I don't think it's under your license to determine a medical surrogate, unless you disagree, Shoal.
I agree.
Okay.
Well, Dr. Crispo, we thank you for your time.
Thank you.
Thank you, Michelle.
Awesome questions. Thanks. And again, I'm in awe of what you guys do every day, and like just absurd care of patients in situations that a lot of hospital folks have no idea you go through. So thank you all for all your hard work, and stay safe.